Hey, BC here for BC Nephro. Thanks for watching. I'm Dr. Brian Cronin, board certified nephrologist and clinical specialist in hypertension. Today's topic, renal scan. We're going to get into these nuclear medicine radionuclide scans, what they are, and clinical indications, what information they can give you. But before we get into that, make sure you check out the other videos at this channel. Check out bcnephro.com, where you'll find articles not only on this subject, but on a wide range of nephrology topics. I'm also on Instagram at bcnephro. Links to all will be in the description below. But now, let's get into it. First, what is a radionuclide renal scan? This is a test where a compound that is taken up and excreted by the kidneys is combined with a radionuclide, which typically is technetium. This is injected into the patient, and images are taken with a gamma camera to measure the location and the intensity of this radionuclide. There are 3 different compounds that are linked to technetium and used in renal scans. The first is something called MAG3. MAG3 is taken up by the kidney and then secreted into the urine by the tubules. This is the most common agent used. The second is something called DTPA. DTPA is also taken up by the kidneys. This is filtered by the glomerulus into the urine, so is excreted by glomerular filtration. The third, least common agent used is something called DMSA. DMSA has good cortical uptake. It is taken up into the cortex of the kidney very well. Now we're going to get into the clinical indications, what information you can get from different types of renal scans. Renal scans have become less common as other imaging, CT or CT angiography, MR or MR angiography, ultrasound with or without Doppler assessment is used more commonly, but there still are some important clinical indications. Some important information can be obtained from these scans in certain clinical situations. Before we get into that, if you're liking this video, please make sure to hit like and subscribe. If you know someone who may want to learn about this topic, please share this video. It's spreading this message word of mouth that helps the channel grow, helps get this education to more people. But now we'll get into 6 different indications for a renal scan. The first indication, and what you're most commonly going to see this for, is for evaluation of obstructive uropathy. This is done by a diuretic renal scan. You'll see it referred to either as a furosemide or Lasix renal scan. Why do you do this? There are certain situations where the kidney may appear obstructed on other imaging. There may be hydronephrosis, for example, on ultrasound, but it's not clear if this is a true functional obstruction or if it's just non-obstructive dilatation. This is where the diuretic renal scan can help distinguish. The radioisotope, typically linked to MAG3, but also can be with DTPA, is injected to the patient. The uptake into the kidneys is assessed, and the rate of excretion into the urinary system before and after furosemide is assessed. Now, if the washout after furosemide is delayed, this is consistent with a true obstructive uropathy that is clinically significant. However, if the washout is prompt, it is suggestive of non-obstructive dilatation. What are the reasons for non-obstructive dilatation? Well, this can be a congenital malformation, congenital variant, or sometimes if there is reflux nephropathy, it can also give this appearance. A second indication, which is also relatively common seen, is something referred to as a differential or split renal function scan. Now, this can be done with either MAG3 or DTPA as well, and what this assesses is the differential function of each kidney. There are times where you may want to assess how much of the patient's kidney function is coming from each kidney. This is particularly important prior to a nephrectomy. Let's say for malignancy, you're going to want to assess if the kidney that's going to be left behind, how well it works, how much function it has. For more information on solitary kidney, I will link another article and video in the description below. So this scan is done either most commonly with MAG3, but it can be done with DTPA. It shows the intensity in each kidney and shows if it's symmetric or different. Now, normally this is going to be close to 50-50, but in some cases, if the one kidney is diseased, it may have less, if any, function. One thing that's important to realize is this test doesn't necessarily tell the absolute function of each kidney, it tells the relative function of each kidney. So the numbers are going to add up to 100%. This is important to counsel patients, as patients may be under a different impression. So let's say a patient knows that they have one kidney that is atrophic and they're a bad kidney, and the other kidney is their good kidney. And let's say you do the split differential function scan and the poorer kidney comes up with 33% function and the better kidney 67% function. The patient may instinctively think that my bad kidney is only working at 33% and my good kidney is still not good, is only working at 67%. That's not true. It's just a relative function between each kidney. In order to assess how well the total function is, how well the good kidney is really functioning, you would need to get an assessment of GFR, which is the third potential indication for a renal scan. Now, if the renal scan is done with DTPA, which is excreted by glomerular filtration, you can not only get the differential split function, but you can get the estimate of GFR. Now, this is not commonly done, as we have other measures. We have other ways to estimate GFR. Most commonly, we use an estimated GFR based on the serum creatinine. If for some reason we don't think the serum creatinine is accurate because of an extreme of muscle mass, we can get an estimated GFR by the Cystatin C or by a 24-hour urine creatinine clearance. For more information on this, I'll link another article and video on Cystatin C, creatinine, and GFR in the description below. But the renal scan, differential renal scan using DTPA, is a fourth way to get this assessment. This is commonly done in kidney donor evaluation, where you would not only want to assess the differential renal function. So if the donor has differential function, you want to leave the donor with the better kidney. One of the cardinal rules of living donation is do no harm to the donor. And you can also do it with DTPA to get an estimate of GFR and really see if this estimate correlates with your creatinine GFR and your 24-hour urine creatinine clearance. Now, a fourth reason, which is not commonly done anymore, is for evaluation of renovascular hypertension. This is done with something called an ACE inhibitor or Captopril renal scan. More commonly, renal artery stenosis is assessed by MR angiography, CT angiography, conventional angiography, or ultrasound with Doppler. But in a patient with hemodynamically significant, that's 60 to 90% unilateral renal artery stenosis and normal kidney function, the Captopril renal scan can give evidence to support renal artery stenosis. In this case, there's a baseline renal scan which shows symmetric flow. You administer the ACE inhibitor Captopril, and if there is decreased flow after the Captopril to one of the kidneys, this is suggestive of a hemodynamically significant stenosis. The fifth reason is for kidney transplant. We've spoken about the evaluation of the transplant donor, but also it had been used in the past for evaluation of delayed graft function in the recipient after transplant. It is not as commonly used anymore. Most commonly done is an ultrasound with Doppler, but if a patient has delayed graft function after transplant, there is a differential. There can be a technical issue such as a problem with renal artery flow, a ureteral leak with the urinoma. There can be acute rejection. There can be ATN from prolonged cold ischemia time, and there also can be calcineurin inhibitor nephrotoxicity. These different clinical situations have different patterns of uptake and excretion on renal scan, but this is not commonly done anymore. The Doppler with ultrasound is more commonly done, and it is also relatively easy to do biopsy post-transplant, where you're going to get a definitive diagnosis of either rejection or ATN. Now, the sixth clinical situation is to assess for kidney scars or pyelonephritis in the cortex, and this is the one that is done with DMSA, as DMSA has the higher cortical uptake. Now, I have not seen this commonly done, and I don't believe it's commonly done in adult nephrology, but it may still have a role in pediatric nephrology. So that's it. Thanks for watching. Again, if you made it this far, you might as well hit like and subscribe, leave a comment, and until next time.